What I would like to do, first of all, is quote Phaedrus, who said, "Things are not always what they seem. The first appearance may deceive many." This sometimes can be a very confusing issue. I would like to address 7 topics in this particular presentation. The first is looking at the HFpEF prevalence. We know that heart failure is quite prevalent, and it's prevalent across the entire globe. It's not limited to one geography, and it's independent of HFpEF, HFmEF, and HFrEF. But we also do know that we're getting better at diagnosing HFpEF, which we were not good at in the past. And if you look at the study on the left, you see the trend towards picking up heart failure patients who are actually HFpEF rather than HFrEF patients. The same thing is seen on the right when you look at those patients with heart failure who wind up hospitalized. So we're better at making the diagnosis and not just saying it's something else. And as I said, HFpEF is not just a geographically limited, but is a widespread problem across the entire globe. Let me move to my second thing. That is the overlap between these two diagnoses of atrial fibrillation and HFpEF. We do know that there is substantial overlap that exists. If you look at the Framingham Heart Study and you take patients with atrial fibrillation, you can see that they just about equally have the same amount of HFpEF and HFrEF. And if you look at HFpEF and HFrEF patients, again, you see that the incidence of atrial fibrillation is significantly higher. So there's that overlap. One makes the other more common and more problematic. And if we look at clinical trials, if we look at AF trials, you see the prevalence of HFpEF is reasonably common. And if you look at HFpEF trials, you see the prevalence of atrial fibrillation is common. So there is substantial overlap in both of these disorders. They occur together, and as I will say, they tend to make each other worse. So the third of these is looking at the outcomes. What happens when you have HFpEF and atrial fibrillation together? Several of the other speakers have already addressed this particular issue, so I'll try to go through it rather quickly. Let's look at the 3 components that I want to address in terms of the outcome overlap. Let's look at heart failure events first. If you look here in terms of hospitalization rates and heart failure readmission rates, whether you have HFrEF, HFmEF, or HFpEF, you can see that the outcomes are similar for these particular components. If we look at atrial fibrillation patients and progression to HFpEF, you can see that there is, if you have atrial fibrillation, a progression to either moderate or to severe HFpEF that is more common. So that presence alone seems to initiate the development of these particular problems on both sides of the equation. What about stroke and systemic thromboembolism? Are they equal or are they different in the HFrEF and the HFpEF populations? Well, if you look at this study here and this meta-analysis for all studies, it was equally divided. And if you subcategorize and take only those that were prospective randomized trials, you can see the same thing applies. So in reality, the population is equally at risk for significant thromboembolic events at the cerebral level. What about mortality, which is also a significant consideration? If you look at registries and you look at randomized trials and you look at the 3 components of HFrEF, MEF, and PEF, you can see that there is, across the board, similar rates of mortality. So this is not a benign disorder that really is not significant. It has equal considerations for negative outcomes. And if we look at the type of outcomes, we might say, well, HFpEFs might have more comorbidities, so they're dying from something else. But that is, in fact, not the case, because if you look here, you can see that about 50% of the patients wind up dying because of cardiovascular causes, irrespective of the type of underlying heart failure consideration. And within that, you can see that the cause-specific mortality in randomized clinical trials is frequently sudden cardiac death. And that's seen in all of these 3 trials right here. So cardiac mortality is higher and sudden cardiac death mortality is higher. So we have to start looking at how we approach the treatment of these patients compared to what the guidelines say in the past. So if we look at the overall outcomes in HFpEF versus HFrEF patients in a meta-analysis, you can see all-cause death, CV hospitalization, and ischemic stroke, there is significant overlap. So we need to stop thinking of this as a totally uncommon and benign disorder and look at it as a more common and not benign disorder. That brings me to the next consideration, that is the pathophysiology. Now that was really addressed very nicely in the previous talk, so I'm going to be very quick on this. But if you look here, you see AF-induced tachycardiomyopathy and atrial cardiomyopathy. We have a normal atria there. When we have a rapid rate, you can see that you're more likely to get fibrosis because of the scarring due to the rates. And then what happens if you have atrial dysrhythmias, you can have changes electrophysiologically. And then those two things, when they combine, can lead to atrial dysrhythmias and lead to scarring, all of which feed upon each other and make pathophysiologic problems more significant. Now, when we look at comorbidities, clearly you can have HFrEF with diabetes and hypertension, et cetera. But if you look at the HFpEF population and you compare them, you see that you are more likely to have comorbidities if you wind up having HFpEF, comorbidities are more common in HFpEF patients than they are in HFrEF patients. So these comorbidities can continue to develop and create significant problems. And this is sort of an example of how this happens. You have these underlying problems, they lead to electrophysiologic and structural changes, which then lead to a transition to both atrial fibrillation and to HFpEF, and they overlap. So pathophysiologically, that is a problem that feeds upon itself with the self mechanism that accelerates. Now let's look at some of the diagnostic considerations. And this is a problem because there's no clear-cut, absolute diagnostic, yes, this is it, no, it is not. It was said by Sun Tzu, opportunities multiply as they are seized. We have some question marks, but can we carpe diem, as they say in Latin, seize the day and see if we can make this better? Well, let's look at some diagnostic considerations. First of all, the uncertainty, some scoring algorithms that are out there, and when and whether you should use hemodynamic evaluations. Let's look first at the diagnostic uncertainty. So first of all, common symptoms are seen in both atrial fibrillation and HFpEF patients, like dyspnea, fatigue, activity intolerance, et cetera. And many times clinicians will say, it's because the patient has atrial fibrillation. And sometimes it is, but sometimes it's a combination of atrial fibrillation and HFpEF, or it's atrial fibrillation alone, or it's HFpEF. So we need to stop saying when you have atrial fibrillation, all these symptoms in a HFpEF patient are all due to the AF, because they may be secondary to that combination. And unfortunately, though, as I'll show in the next slide, there is no single definitive diagnostic criteria that is 100% accurate. But before you actually make the diagnosis, it's important to take a step back and to look at all of the other cardiovascular problems, like a restrictive cardiomyopathy, hypertrophic cardiomyopathy, et cetera, as you see on this slide, that could be operative. We have to look and evaluate, rule those out. If those are present, then those are causing the problem. But if they're not, then we're left with the conundrum, well, what is going on with this particular patient? And that's where HFpEF may be much more common and likely to occur. You also have to look outside of the box from cardiovascular problems to other problems. Some of these people have have intrinsic skeletal muscle problems. Some of them have pulmonary problems. Some of them have psychological problems. Those also need to be evaluated, and they have to be put into the proper context. Cardiac is certainly the most common, but other factors need to be considered. So how can we make the diagnosis? Again, it's not perfect. And I show this example here. These are hard criteria. When these people are participating in this athletic event, you see the person on the left has crossed the finish line first. There's no question. That person won this particular event. But that is not how we make the HFpEF diagnosis. It's more like this figure skater who's skating, and then a bunch of judges look at it and go, this one was better than that one. This one won the award, this one did not. The criteria are not absolute or perfect, but there are several scoring techniques, as you can see right here, that have been developed using structural considerations, using anatomical considerations, using physiologic considerations, using clinical considerations. And they make it so that it could be unlikely, which is depicted over here in the red, possible, intermediate there, and then very likely that you have a diagnosis of HFpEF over there on the right. So that's where it's very highly likely. And again, if you look at studies like the atherosclerosis risk in the community study, you can see that those who met the criteria that was very highly likely, who had atrial fibrillation, about 42% of those patients actually had HFpEF. Which is interesting. And if you look at this data from the Mayo Clinic patients in folks who had an ejection fraction that was over 50% and had new onset AFib versus those who were matched with sinus rhythm, you can see that the development of atrial fibrillation was much more likely, 62% in this study, to lead to HFpEF than those patients who had sinus rhythm because of the interaction and interplay between the two of them. So when might you need to use hemodynamic considerations? It's for that intermediate group. If it's low, don't worry about it. If it's high, you have a pretty good likelihood that that's the diagnosis, although there are some uncertainties and you need to rule out other things. But it's in that middle group. Which way is it? Is it something else? Is it HFpEF, et cetera? And that's where hemodynamic considerations are important. So you do your usual thing as a clinician, as a physician. You evaluate the patient clinically with routine exam, routine questioning, and routine minimal testing. And then you come up and see it. I think it might be HFpEF. You do your score, and if you get low, you can say, look, it's unlikely that this is the problem. We should look for other causes for why this patient is symptomatic. Conversely, if instead it's very high, you should probably again say, look, this is HFpEF. Let's orient treatment in that direction. But if it's in that intermediate zone where you're not sure, this is often where clinical hemodynamic analysis is relevant. And as you see here, this is a mixture of sinus and atrial fibrillation patients. And they went through testing at rest and with maximal exercise. And you can see the filling pressures here were 1 millimeter of mercury. And then with exercise, you can see no HFpEF, they stay low, only going to 5.4, whereas significantly rise in the patients who have HFpEF to a much higher level, 3 times that. Similarly, over here, you see in sinus rhythm patients, rest and maximized exercise. And you can see, again, the no HFrEF patients have a higher cardiac output and a lower pulmonary capillary wedge pressure, whereas those with HFpEF have less cardiac augmentation and output and actually rise to a higher level of filling pressures. So those are ways in which you can differentiate the presence or the absence of HFpEF. In this particular study, they came up with a ratio for the pulmonary capillary wedge pressure to the cardiac output and created a slope of 2. And you can see that it does really significantly allow one to be able to separate those patients who do versus those patients who do not have HFpEF. And on the right, you see over there that those patients who fit this diagnosis of HFpEF based on that slope wound up in point of fact having a higher risk of mortality and other cardiac events over time. So let me give you a very brief consideration of treatment considerations. The great American physician William Osler said, the good physician treats the disease, but the great physician treats the patient who has the disease. So in terms of some general treatment approaches, I'm not going to spend much time on that. We know you got to look for comorbidities and maximize the treatment thereof. That's been said by the other speakers. It's also been said how different drugs can have benefit for HFpEF patients. Again, being electrophysiologically oriented, I'm not going to address those specifically. There are also some new non-pharmacologic approaches that are developing as well and can be utilized in this particular patient population. Again, I'm not going to get into them in any detail, but it's something that we should keep an eye on. But what about the rhythm effects? And this has already been addressed, so I'll go through it very quickly and then finish up. If you look at using a drug, for example, in this case, dronedarone versus placebo, you can see that across the board of no heart failure, HFrEF or HFmEF, you can see that there is potential benefit in terms of the incidence rate. If we look at the HFpEF changes that occur after ablation, you can see here in this particular study that there were BNP, left atrial dimension, and cardiothoracic ratio and chest X-ray improvements with ablation. But again, these are selected small series patients, not large prospective randomized trials. Also, we do ablation and we treat those patients mostly to make them feel better. So if you look at these two studies, you see that there was an improvement in clinical data that are used to assess quality of life indicators from these particular two studies when patients underwent ablation. And also here, if you look at the time to recurrence, and this is probably why in this analysis and this particular study that the time to AF recurrence was improved, and therefore the progression from paroxysmal to persistent was lower. So again, there is evidence in small series that are not perfectly done that ablation can have salutary effects, but it's not perfect. And again, in here, you see lower hospitalization rates, both in general and for cardiovascular reasons and for all causes when you put it together. So if we look at this meta-analysis for heart failure events, this is where I think the concern lies. If you look at heart failure events and cardiovascular mortality, in the HFrEF patients, the data is very strong. But if you look at it from the HFpEF patients, as our earlier speaker said, you see that there is some overlap, and there's not really 100% clear. There's data showing benefit in small series, but it's not across the board, and there are question marks. This was a nice study that was done very recently from Changsheng Ma's group, and as you can see, they looked at the CHA2DS2-VASc score, and they found that if you had a lower score, you were more likely to have less cardiovascular events like death, et cetera, et cetera. And as a result of that, I think that we are at the point where, we have to get more data to figure out what is the best approach. We've made inroads, but we haven't solved the problem. So in summary, I would say HFpEF is more frequent than is typically recognized. HFpEF and atrial fibrillation very commonly overlap. Adverse outcomes in patients with atrial fibrillation and HFpEF are significant. They're not minimal. There are comorbidities that are more frequently associated with the presence of atrial fibrillation and HFpEF. And HFpEF diagnostic criteria, unfortunately, are not perfect. The algorithms are helpful, but they do need to have improvement. The treatment options are still a work in progress at the general level and at the specific arrhythmic level. And in general, atrial fibrillation ablation appears to be beneficial in some groups, but we need further refinement to identify exactly responders versus non-responders and whether antiarrhythmic drugs or medicines are better in specific subpopulation groups. So I thank you very much and leave you with a comment from Kung Fu Tzu, who said, be the change you want to see in the world. We don't have all the answers yet to this problem, so let's together figure out how we can get there. Thank you very much for your attention.